It's a great pleasure to be here, and I again want to thank the organizers and Dr. Rachel Bond for inviting me to speak today. I'm going to be talking about heart disease in rheumatological, autoimmune, and inflammatory disease in women. This is a topic which I have studied for many years. We have focused on vascular disease and vascular inflammation, so you will find that a lot of what I focus on is vascular disease, but it is truly very important for women because it's often missed. And it's important to understand right from the beginning that these autoimmune rheumatological disorders are considered a major risk factor for simple, straightforward atherosclerosis. It's up there with diabetes as one of the main causes for accelerated vascular disease and one of the main reasons for increased mortality. So autoimmune rheumatic diseases, often referred to as ARD, they affect about 8% of the population, but of that 8%, 78% are women. If you look at rheumatoid arthritis, cardiovascular disease is seen a decade earlier in rheumatoid patients. There's a twofold increase in myocardial infarction, heart attacks, and heart failure, irrespective of age, or past coronary disease or traditional risk factors. As I noted, it's similar in risk to having diabetes. So what I would like to present to you overall in short form is the incidence in women, the pathogenesis, how to diagnose, the treatment, and just a little bit on research. So systemic autoimmune diseases, which I'm sure you all are aware, include the connective tissue diseases such as lupus, rheumatoid arthritis, systemic sclerosis, mixed connective tissue disease, the vasculitides, which I have been researching, and these are usually broken down into small, medium, and large vessel inflammatory vasculitis. And the one we have focused on is more rare, the large vessel vascular diseases, Takayasu's and giant cell. And in addition, granulomatous disease with sarcoid and autoinflammatory diseases. Women do predominate in most of these areas that I've discussed and mentioned above. In particular, there's the 9-to-1 ratio of female to male with rheumatoid arthritis. With lupus, there are 9 women to 1 male. With sclerosis, 3 women to 1 man. With mixed connective tissue, 3 women to 1 man. Dermatomyositis, 2 females to 1 male. And with systemic vasculitis, in particular Takayasu's vasculitis, again, more women. One exception is Kawasaki's disease, which is male predominant. You can have multiple different areas of the cardiovascular system affected by any of these autoimmune disorders. You can have pericarditis and pericardial effusion, which I believe many have seen. You can have myocarditis and cardiomyopathy with both heart failure and rhythm disturbance, and even heart failure with preserved ejection fraction and fibrosis. You can have endocardial involvement with valve disease and thrombotic complications. And as mentioned at the beginning, coronary artery disease and acceleration of atherosclerosis. You can also have involvement of major vessels with aneurysms and thrombosis, and finally complications with hypertension. So this is a very severe complication of the rheumatological disorders. The causes of heart failure in women in ARDs, these acute rheumatic disorders, include vascular disease, both micro and macrovascular, with ischemia or Raynaud's. You can have myocarditis and heart failure, heart damage, and structural with valvular disease. So this brings us to the next question. Why are women more often affected? And the truth is, we don't entirely know. There are studies that have shown that estrogens can elevate autoantibodies and amplify autoreactivity self-reaction of T and B cell responses in the immune system. We have GWAS studies of genetic changes in postmenopausal women where estrogen has been decreased, and we see alterations in blood pressure control by the renin-angiotensin-aldosterone system and altered endothelin, nitric oxide, reactive oxygen species. And we see specific changes in genes related to T and B cell responses. So the estrogen in women does alter our immune responses. The other main point to remember here is that cardiovascular disease is underdiagnosed in ARD patients. It's often missed. This is very important because the prognosis in ARD is mainly linked to cardiovascular disease. There is increased mortality and morbidity, and the actual cause of death is often not the underlying systemic autoimmune disease, but rather the cardiovascular complications. The clinical symptoms can be missed. They're often not typical. They're interpreted as signs of underlying systemic disease. They're missed due to diastolic dysfunction with heart failure versus congestive heart failure with dilatation and systolic dysfunction. And thus, we often do not investigate far enough or in enough depth to figure out exactly what's going on, what's causing the symptoms, when indeed they can be due to cardiovascular disease. And the other main issue is that, in fact, cardiovascular disease can be neglected because we are looking for the systemic disease and ignoring the actual underlying cardiovascular disease that's a complication. And if you look in the right upper quadrant, just to point out the mortality, the reduced survival in rheumatological patients is often associated with accelerated cardiovascular disease, vasculitis. The chronic inflammation can affect the vascular system and the cardiovascular system, causing accelerated atherosclerosis. You see the inner lining of the artery no longer functions well, becomes damaged, and induces an inflammatory response. You then get heart muscle and vascular inflammation, and as I noted, accelerated atherosclerosis. It's the same problem we see with typical routine atherosclerosis, if you can ever call it routine. And this indeed, when inflamed or unstable, causes the plaque to rupture and causes an acute thrombosis. So there is probably a spectrum of interaction of underlying atherosclerosis and accelerated disease with inflammatory vascular disease. And just so you know, we all have early atherosclerosis from age 11 on in our arteries. The other complication is that many of the drugs used to treat these ARDs, the anti-rheumatic drugs, increase the risk of cardiovascular disease. And of course, the first and foremost is the steroids. They're highly effective, but they alter our lipids. I don't know if you can see my cursor, but you have altered LDL, triglycerides, HDL. You have accelerated atherosclerosis, in addition to diabetes in these patients. So coronary heart disease, just so you're aware, routine atherosclerosis is not an insignificant problem in women. Aside from being complicated by ARDs, the lifetime risk for individuals at age 40 is 49% in men, but 32% in women. Even those free from cardiovascular disease at age 70 have non-trivial lifetime risk of developing cardiovascular or coronary heart disease. 35% in men and 24% in women. There are 307,000 deaths in men and 290,000 deaths in women in the US per year. And if you look in the right upper quadrant, again, you'll see an angiogram that's from a case I did years ago, required a stent, but in a female, not particularly old, who had unstable angina and atherosclerosis. So what are the risk factors for women? Well, all of the usual are included: smoking, renal failure, diabetes, diet, obesity. Low HDL is apparently more important than higher LDL in women. Lipoprotein A is a marker for increased risk in women. Total cholesterol is important in premenopausal women or at very high levels, and triglycerides are very important in older women. And as mentioned, the ARDs. So when we look at the risk in women for cardiovascular disease, we've just been through many of them, but of course there's hypertension, dyslipidemia, family history of premature heart, metabolic syndrome, diabetes, physical activity, inactivity, obesity, smoking, subclinical atherosclerosis, poor functional capacity, but you'll notice in green, autoimmune disorders. They're a major contributor. And then one other factor is preeclampsia history and gestational diabetes. So here we are, we have our acute rheumatological disorders definitely causing increased risk. When looking at patients with ARDs, we tend to think of the main symptoms: fever, fatigue, weight loss, arthralgias. In the vasculitic syndromes, such as Takayasu's, there's pulse differential. The labs, I'm sure you're all aware, are the typical ones with CBC, creatinine, liver function, SED rate, CRP. And then we look for serologies for viral hepatitis. We look for cryoglobulins. For lupus, we look at ANA. We look at complement levels. And then we move on to further diagnoses with simple chest X-ray, echocardiogram if there's suspected cardiovascular damage or heart failure. And of course, then we can go on to high resolution CT or MRI, MRA. If a patient has symptoms suggestive of angiitis or vasculitis in the central nervous system, they may actually end up referred to a neurologist for an LP. And if you suspect temporal arteritis from giant cell, then you get a temporal artery biopsy, which is performed by the ophthalmologist in the office, and minimal side effects and acceptable for diagnosis. So this brings us to inflammation. I find this fascinating, perhaps because I've studied this for many years, but this gentleman back in the 1800s actually discovered inflammation. So when you have damage to any part of your body, the first response to any damage or any infection is inflammation, not an immune response. And he found this by taking transparent starfish and putting tangerine thorns into the starfish. And he found that there was a visible massing of inflammatory cells very early on, long before you would have had an immune or antibody response. And he did the same thing with microbes infecting Daphnia. Apparently he was quite an ornery gentleman, but his discovery is one of the pivotal points in our understanding of inflammation. Inflammation in the artery is something that begins with damage to the inner lining of the artery. So right here at the endothelium, the innermost lining of the artery that surfaces or interacts with the blood is where your mononuclear cells, your monocytes, will interact with damaged arterial wall and crawl through, or diapedese, into the underlying layer, forming a thickened intima and a plaque. And then you end up with fatty cells, macrophages full of fat, and they proliferate along with smooth muscle cells from the middle layer of the artery, and you end up with this atherosclerosis. If you have unstable or inflamed atherosclerosis, you start with these monocytes crawling into the artery, building up the plaque, and then the plaque can become ruptured or unstable, in part due to inflammatory cells eating away at the surface because they recognize it as abnormal. And then you have a clot forming and the artery occludes. And this causes either a heart attack or stroke or limb ischemia. So as we noted, this accelerated atherosclerosis is seen in autoimmune and inflammatory diseases. The diagnosis is often missed because we focus on systemic ARD. And one of the other problems we've noted is that women have often been treated with calcium channel blockers and diuretics for risk factors such as hypertension, but they're less often given drugs, even after a cardiac event, with proven benefits such as beta blocker and ACE inhibitor. So this is another good reason for being very aware of the problems associated with ARDs and accelerated vascular disease. The large vessel vasculitis I'm going to use as a principal example of these ARDs. Giant cell arteritis and Takayasu's arteritis are rare, but they cause severe systemic disease. Many people believe they're variants of the same disorder, and they're considered an orphan disease. There's about 18 in 100,000 patients. This was first discovered by Kussmaul in 1866. They actually thought it was due to worms, and they later retracted that and said it was not. The artery will look like this. Top right corner, you'll see a completely occluded, consolidated artery with thrombus and inflammation all the way through the artery wall. In giant cell, the age is usually a bit older, over 50, Takayasu's younger women, and you see sudden blindness, strokes, aneurysms, dissection, pulseless disease, jaw claudication. And I have seen one young lady who'd already had coronary bypass, carotid bypass, and all of her grafts were occluded. She was about 46. So it's a devastating disease. And this is a symptom, and also will show you how bad this vascular inflammation can be. And it's found in many of these autoimmune diseases. We believe that cells that signal antibody formation, as well as T cells, are closely involved in developing this disease. The cytokine interleukin 6 and TNF are important in causing the accelerated inflammation. Macrophages are also activated, and we now have new disease treatments that seem to be improving the outcomes gradually. But again, we have marked recurrence, 50 to 70%. There are also possible infectious causes, just in case you're interested. Herpes, TB, and chlamydia have been implicated. So how do we diagnose? Well, you diagnose and look for cardiovascular disease in patients at risk with your typical history and physical and a good degree of suspicion. Then you do your blood tests and imaging. I've left this in the slide stack for those that are interested in how to diagnose Takayasu's, but I won't go through this in detail. The imaging is most important if you suspect cardiovascular disease. I would often start with an echo and then progress to an MRA or CTA, and you can also do PET scanning or nuclear stress. As noted above, there is often a mismatch between the clinical findings, the biopsies, and the imaging, but you have to look. And these figures are fascinating from PET scans of patients who have had polymyalgia rheumatica and giant cell, and you can see involvement of the subclavian arteries, the aortic arch, and the abdominal aorta. And here is a patient who had marked narrowing of both carotids, and after high-dose steroid treatment had improvement in the diameter of the carotids. So how do we treat these patients? Well, we want to get in and treat at the baseline. We want to do preventative treatment. We want to work on all the classical treatments that improve outcomes: diet, exercise, weight loss, and then also proceed with aspirin as indicated, lipid lowering where indicated, and if they have prior disease, prior proven cardiovascular, I would strongly advise at using drugs with proven benefit after events, such as heart attacks. So ACE inhibitors, ARBs, beta blockers, aspirin again. And if necessary, then you would consult the surgeons for intervention with PCI bypass valve. The treatments for the ARDs are, of course, also important, the steroids and immune modulators. High-dose steroids are often used, but as noted, they have marked side effects, often have to be discontinued. The rheumatologist will then proceed with methotrexate, which has shown some benefit, as well as cyclophosphamide, cyclosporin, but then we end up with side effects and you have to proceed to biologics, such as IL-6 targeting antibodies or anti-TNF medications, which have improved outcomes. And this is just to let you know that there are a lot of new therapies in use for lupus, B-cell depletion treatments, and T-cell co-stimulation and cytokine therapies, such as the IL-6 antibodies. And they are showing benefit. So what do we do? Well, I have to tell you about our research just a little bit at the end, because we have been studying vascular disease long-term, and we've developed a new class of drugs derived from viruses, which is fascinating. It's like taking penicillin from mold. So when a virus infects the host upregulates its immune response to kill off the virus, and the virus fights back. The virus makes proteins that block the immune response, and we've taken not the virus, but pure proteins, and we use these as new treatments. And we've used them in our lab and in multiple labs to treat inflammatory diseases, anything from atherosclerosis to virus-induced inflammation of arteries, lung hemorrhage, as well as transplant. And this is both my lab and multiple other labs. So we have a series of new therapies. And we actually did, in our small group in Canada, set up a 7-site clinical trial. We used one of these called a SERPIN, which targets both clot-forming and clot-dissolving pathways, blocks inflammation. And in our small study, phase 2, we saw reduced markers of heart damage after stent implants in coronary disease patients with no side effects and no neutralizing antibodies. So very encouraging. And we have now built a modified protein called modified SERP1. And if you look at the bottom of this slide, you'll see that when we treat a model of lupus-induced lung hemorrhage, it's a rare complication of lupus, highly deadly. There's a 50 to 80% mortality, and the treatment is limited. And you can see on the bottom that the lungs down at the bottom of the modified SERPIN treatment have much improved with much less hemorrhage. They're no longer dark, they're now white. We've measured this as a diffuse alveolar hemorrhage score, and our histology shows lacier lungs at the bottom with reduced risk of hemorrhage. So this is what we're working on and interested in. So if anyone's interested, I'd love to have you contact me at some point. It is still a new drug, but has promise, great promise. And this is where we work at the BIODESIGN. At the bottom is funding that we've received over the years in Canada on the left, and at the University of Florida, and now here at the BIODESIGN, the American Heart, and the NIH. And this is my lab. These are the people that have done all the important work. Dr. Jung, Dr. Yaron, my grad student who's been working on some of these projects, my undergrad and medical students that have worked in the lab, and our lab mascot, Maximus or Maxoma, which is just a joke because we take our drugs from a virus that is a myxoma virus. And that's where I'd like to end, other than this is a medical mission I do every year, and my daughter goes with me, and the drug we use is called a SERPIN. And she was wearing her SERPIN cap. Well, she used to go with me every year. So that's the end of the talk, and it was a great pleasure. I'd welcome any questions.